This baby has a complete bilateral cleft of the lip and palate. In this particular case, we have used pre-surgical orthopedics. We don't routinely, but in unilateral clefts. But in bilateral clefts with prominent premaxilli, we often ask the orthodontist to put a plate in to stop collapse of the segments, and then to gently strap to push the premaxilla back. Although I use the microscope routinely for all palate repairs, I actually don't use it for lip repairs generally, because I find that I need to move around more and obtain a more three-dimensional view. But for the purposes of this filming, we are using the microscope to show the picture, because I think it's going to give the best view for those watching the video. So I'm going to show you a picture of the baby right way round before surgery, and the rest of the picture will be reversed, will be inverted. In other words, the surgeon's eye view, so that the upper lip will be at the bottom of the screen. So here's the baby at the age of 3 months, a large premaxilla shown from below, good sign of forward maxillary growth, and you can see the lateral views with the premaxilla and prolabium angled forwards, and the palatal view to show the voma in the midline. So this is now the surgeon's eye view, the surgeon sitting at the head of the table, the inverted view as seen through the operating microscope. It's asymmetrical, which makes life a little difficult. There's also a little natal tooth, as you can see on the left, sitting on the arising from the premaxilla. There's some deviation of the septum. We have largely abandoned pre-surgical orthopedics for unilateral clefts, but we still do use pre-surgical orthopedics for those bilateral clefts where there's a very prominent premaxilla. But I have to say it's gentle pre-surgical orthopedics. I think in the past we've been far too energetic about trying to push the premaxilla back. It involves a plate in the palate to prevent narrowing down of the lateral segments behind the premaxilla, while some gentle strapping is applied to the prolabium and premaxilla. Simple strapping tends to just narrow the arch and shut out the premaxilla. I remain agnostic, uncertain about NAM, nasoalveolar moulding. There's the natal tooth arising from the premaxilla, which we'll remove. I remain unsure whether nasoalveolar moulding, NAM, is a good thing. It's a major intervention. It involves quite a lot of time and effort for everyone involved. I can't help feeling it's not really appropriate for many countries where such intervention is really not feasible. We don't do it. However, I can see the argument for bilateral clefts particularly, and remain to be convinced whether it really is, whether the extra cost and effort and inconvenience is justifiable. One of the difficult things about bilateral clefts is if the premaxilla is too low. In this case, it's not particularly low, but as you saw from the lateral view, despite some gentle pre-surgical orthopedics, it is still quite prominent. The columella is fairly short, but not as short as some, and it's a nice, broad, substantial premaxilla, and quite a nice prolabium. The decision about which technique to use is one that varies depending on the type of the cleft. I have been influenced by many people, and the technique that I'm going to use in this case is a combination of techniques by ideas by many surgeons, influenced by Harold McComb, by Mulliken, Millard of course, Manchester to a degree in some cases, but not in this case, the Oslo team for popularising Vermarine flap closure of the anterior palate, and so on. So the first decision to make is whether to use what I call the Mulliken or Millard technique of reconstructing the prolabial or the central vermilion and mucosa from the lateral segment, or whether to use the vermilion of the prolabium. Here I'm marking the landmarks of the center of the prolabium and the midline of the columella, and the sort of width of prolabium which I plan to construct. So there's the midpoint and the two lateral points. I'm going to do a Mulliken stroke Millard here. Because the prolabial white roll is not very well developed, because the prolabial mucosa is not very good quality, and because there's a nice white roll in the lateral segment that can be brought to the midline. The alternative, which is, if you like, a modified Manchester technique of using the prolabial mucosa, is, I think, still appropriate in some cases. If the prolabial white roll is good, it's the reverse of those factors that I've mentioned. Prolabial white roll and mucosa is good, and the lateral segment white roll is poor. So I've marked the lateral points. I preserve the C flaps, but not necessarily all of them, because they're often too large. And I still make small transverse incisions at the alar base. In the prolabium, we're going to preserve that amount of mucosa to line the sulcus, the inner layer of the sulcus, but sacrifice the junctional area. So again, an incision, we'll plan the incision, a fairly short lateral incision at the alar base, but not extending all the way around the alar base. Many surgeons have now abandoned that. I still like to keep some of that C flap in the nostrils to create the nostril sill, and be available not for traditional forked flaps, but for giving some tissue for columellar lengthening in the future. In the lateral segments also we sacrifice just the junctional area, and that incision, so that is the junction between mucosa and skin. That incision goes down to the anterior surface of the maxilla. So I would say that I do more Mulliken type repairs than Manchester, but still do some Manchester repairs in some patients. I think in pigmented patients it's generally better to do a Mulliken, because that central prolabial mucosa never looks right. And in Caucasian patients, in white patients also, it's very frequently you're left with an area of wet mucosa which is visible and crusted. Now we're planning the Vermarine flap. An incision down the midline of the voma and around the side of the premaxilla, on the oral side of the groove, which is the groove between the premaxilla and the vomer. Somewhat different from a unilateral cleft, where there's often a very deep groove because the vomer is so tilted. Slightly off screen here. We're also going to make lateral incisions in this, just on in the sulcus, or actually slightly above the sulcus, and that will, those incisions will go through the periosteum, and the anterior maxillary periosteum will be elevated. I personally carry out that lateral mobilization subperiosteally rather than extraperiosteally. We usually carry out some measurements at the beginning of the procedure, just to record the width, the alveolar width, the gap in the lip, intercanthal distance. But I think the most valuable ones are the length, the widths of at the alveolus, and particularly at the back of the hard palate. We also, wherever possible, take dental impressions at birth and at this stage, although we are beginning to think that that's not justifiable in all cases. Now just going to tattoo the key points, just the 4 key points. What will become the junction between the lateral segment and the prolabium, the more medial mark, which is becomes the midline, the key points on the prolabium at the white roll, the midpoint, and the left side. I don't personally measure lengths, and I eyeball the landmarks. I think measuring is a bit of false science, in that it all depends how much you stretch the skin. So again, that point will become the junction between the lateral segment and the prolabium at the white roll, and the medial point will become the midline, will join the midline. And now some local anesthetic. We use 0.5% lignocaine, lidocaine, xylocaine, whatever you want to call it, with 1 in 200,000 adrenaline. And some of that local anesthetic is put into, there's a bit going into that natal tooth, put in a subperiosteal plane, and also down the lateral nasal wall, and into the, that's again a little more into that natal tooth, a little bit in the prolabium. This operation is being done at the age of 3 months, which is our planned ideal date, and the subsequent palate repair will be done at 6 months. My general philosophy in bilateral clefts has changed a lot, and throughout this procedure I'll explain why certain elements have changed. But the general philosophy has been to, if anything, become more conservative rather than more radical. I think in our attempts to push the premaxilla back into position by pre-surgical orthopedics, by over-tight closure of the muscle, we've actually damaged some of these the growth for some of these patients, certainly pushed the premaxilla back, retroclined it, and I think contributed to maxillary retrusion in some. So, as I said earlier, the pre-surgical orthopedics is now much less aggressive than it used to be, and if necessary, I'm quite happy to accept going back to complete the operation, complete the lip repair later, if necessary. This is a modified gag. We've modified it for the use of the operating microscope. I don't actually use the microscope for lip repairs. Occasionally I have, but I don't find it particularly helpful. But it's a modified modification of the Dot Kilner modification of the Boyd-Davis gag. So this is now exposing the palatal cleft. And the tilted premaxilla. Sometimes the gag is hardly wide enough to engage the lesser segments. As you can see, the cleft's a little wider on the left side as the voma is a bit closer to the right. As far as the vomerine flap is concerned, I've gone through many stages. I began by, well, at the very beginning, in the very early, my first couple of years as a consultant, I began by repairing the lip one side at a time. I actually only began to use the vomerine flap in both unilateral and bilateral clefts in 1993, influenced by the results of the Oslo team. So this is just showing the incision again in the midline of the voma, and then around the side of the premaxilla. I began by doing one side vomerine flap only, because I was concerned about the vascularity of the premaxilla and the prolabium if a full radical vomerine flap was done on both sides. I then moved to doing a full vomerine flap on one side and a limited one on the other side. That seemed to be okay. I then, in a small number of cases, decided I'd be more brave and do a full vomerine flap on both sides. And although I don't believe that I've actually lost the premaxilla, I have been concerned about the blood supply. So I've stopped doing that, and I've gone back to the original, which is, there's the pre-vomerine suture. So doing a radical vomerine flap on one side and a limited vomerine flap up to the pre-vomerine suture on the other. And this means that by definition there is going to be an alveolar, an anterior defect on that side. Here we are putting some local in, first in the palatal shelves and then into the inferior turbinate, which is just becoming a little bit distended, because I'm going to be freeing the lateral nasal wall and if necessary dividing the inferior turbinate to achieve anterior mobilization of the lateral elements. Again, some local anesthetic into the palatal cleft, and that incision at the margin of the cleft in the lateral segments goes back into the very front part of the soft palate at the junction of the oral and nasal layer, which is usually around a little on the oral side. It's exactly where I would later make the incision for the soft palate closure. So a bit more local anesthetic into the voma on both sides. This repair is being demonstrated using the operating microscope because it gives the best view for recording. As I said, I don't normally use the microscope for a bilateral cleft repair, but this particular repair was done for a demonstration. And it's a moderately difficult bilateral cleft. So we'll get rid of that little natal tooth. It'll be interesting to see whether this child does have a lateral incisor in the premaxilla on that side, and whether that's a supernumerary or whether it is the deciduous lateral incisor. That seems to be a variable phenomenon. Now that's showing where the incision goes, assuming that we make do a full vomerine flap on that side, on the left side. You can see that groove, and the incision will be made just on the oral side of the groove. The groove between the premaxilla and the vomer. I'm going to make that incision at this stage. So it goes round, down to bone, from the midline, from the vomer, and then around on that oral side, just on the oral side of the groove. Subsequently raising the vomerine flap from that groove is often a little difficult. We've obviously a little bit of leakage around the throat pack, as you can see. And then making the incision from the alveolar margin up to the lip, and that incision which leaves the white roll inferiorly, small incision in the alar base, I use for all surgery actually the barren handle, which allows you to rotate the blade. There are a number of scalpel handles around that allow you to rotate easily, but I do think that makes a big difference. Very difficult to handle with a flat or to manage with a flat-handled scalpel. Now that incision through just above the sulcus, above the fixed point of gingiva, and down through the periosteum. And this part of the technique is exactly the same as in a unilateral cleft, which is demonstrated on another DVD, which has been demonstrated. And then with a dental scaler, elevating in a subperiosteal plane. You need to be very careful at this point. The anterior maxilla is very thin, and there are tooth roots, or there are small teeth just beneath there. So particularly on that prominent area there, you need to be very careful not to go through the bone. It becomes more solid laterally and medially around the piriform aperture. And then, having got into the subperiosteal plane, the dissection is carried up to the infraorbital nerve. Some surgeons actually go above the infraorbital nerve, but I don't do that. But I'm elevating that periosteum up to the nerve. And then down the lateral nasal wall, around the piriform aperture and down the lateral nasal wall. Then going down the lateral nasal wall, you can actually insert the scaler down and find the junction between the lateral nasal wall, or the nasal layer of the palate, if you like, and the oral mucoperiosteum of the palate. So it's easy not to quite get into the subperiosteal plane there. Now we're making we're releasing the periosteum just below the nerve, which is just near that sucker. So the periosteal release begins at the sulcus and extends right round to the piriform aperture, so that that little island of periosteum is completely free. And the reason for that is that periosteum is not very elastic. So it's then stretched out, exposing the nerve. There's the nerve, just near that scala, that white structure there. That's the infraorbital nerve. A good idea is to put some longer-acting local anesthetic block, bupivacaine, Marcaine, for example, into the nerve at that stage. In fact, it's better put in before you make that periosteal incision. Now, stretching down the prolabium to make the incisions in the prolabium. This prolabium is probably about 5 millimeters wide, not as narrow as John Mulliken makes it. So making those two incisions just at the vermilion margin from the midline to the two lateral points of the prolabium. And then the marking out or incising the lateral borders of the prolabial flap. And then the lateral margins of the C-flaps. Relatively, they've been made somewhat smaller, not using all of that tissue, because they really just become too big. As I said earlier, I like to preserve them because I like the nostril sill that's produced. But the secret is to try to make sure that that those C-flaps lie down horizontally in the floor of the nose and are not significantly seen from the front in the lip. I've abandoned doing full forked flaps at the time of the or at any stage actually, but this tissue is sometimes used in a Vita Y Cronin type lengthening of the columella at some stage in some patients, although again become much more conservative about that. Now elevating both the C-flap and the prolabial flap in a leaving it reasonably thin. And then we'll sacrifice just the junctional area of that prolabial mucosa, but keeping a reasonable amount of the prolabial mucosa for the inner layer of the sulcus. I think making a good sulcus is as important for the mobility of the lip as getting a good muscle repair, in that you need to be able to move your lip from side to side. It needs to be mobile over the premaxilla. Now similarly making the incisions on the right side. Again, just preserving the white roll. Short transverse incision at the alar base. And that's going to become the central part of the prolabial mucosa, white roll and mucosa. And again, making that, extending that incision down at the junction of the nasal lining and the lip mucosa, and sacrificing just the marginal strip. This is an unedited video, DVD recording, because I think it's quite important to see both sides and to see the bits that are not so easy. I still think that bilateral clefts are difficult. They're certainly the big challenge. Every aspect of them, I think, is more difficult than a unilateral cleft, except for one thing, and that is that in symmetrical bilateral clefts you do have the advantage of symmetry. You're not trying to match, as in a unilateral cleft, the cleft to the normal. So this is the fairly small mucosal stroke skin junctional area that's sacrificed. I do the great majority of this dissection with scissors, with a knife, not scissors, because I think a knife is much less traumatic and much more precise. Now we'll make the sulcus incision, or the incision just above the sulcus on the right side. You can't quite see it, but just above the sulcus, just above the attached gingiva. In incomplete clefts, for example, I wouldn't make that incision. The basic principle is do as little as you can, or as little as you have to. So in an incomplete cleft, if it wasn't necessary to do that for mobilization, I would actually tunnel down in the sulcus and just release the periosteum. And in a very undisplaced unilateral bilateral cleft, I wouldn't mobilize at all. So once again, we'll elevate the periosteum from the anterior maxilla using a dental scaler. Again, being careful of that area near the piriform aperture where the maxillary bone is very thin and where tooth buds are very close to the surface. On the other hand, you do need to be subperiosteal to get in the right plane. Even a knife will go through that thin bone, so be careful. So we're now extending that subperiosteal dissection up towards the piriform aperture and then up towards the infraorbital nerve. And a lateral release is made often in the mucosa laterally, just to allow it to come forwards. And as I said, on the other side, the periosteum is then released to make a little island of periosteum. Probably the very similar to the island of periosteum that Skoog used to convert into a flap for reconstruction of the alveolus, but it's not used for that purpose at all. It's simply to lift up. There's the lateral release in the mucosa, and then releasing the periosteum, just carefully dividing through the periosteum all the way around over the infraorbital nerve to the piriform aperture, and being very careful while incising over the piriform aperture, over the infraorbital nerve, because it's very easy to divide it. Or to damage it, at least to some extent. And then stretching it, and again that white infraorbital nerve is seen there. So just releasing the periosteum a little further. Around to the piriform aperture. In patients with very prominent premaxillas, as I've said earlier, where it's not possible, I believe, to produce a tension-free muscle repair, for example, I make various compromises in this repair, but I will always do that lateral release, even if what I'm doing is almost like a lip adhesion, where I don't dissect the muscle, don't necessarily narrow the prolabium. I would still carry out this lateral release. And there's the infraorbital nerve under a higher magnification. I think that in many people's hands, even a lip adhesion has a high failure rate. But by doing this lateral mobilization at this stage, you reduce the tension in the repair. And then I make a decision. So in a more prominent premaxilla than this, I'll make those lateral incisions, and I'll then make a decision whether to narrow the prolabium at this stage or whether to leave it wide, and also whether to attempt a muscle repair. So sometimes I'll narrow the prolabium, but not prepare the muscle, not mobilize, not dissect the muscle. Sometimes I won't narrow the prolabium at all, and attempt not to make all of the definitive incisions. Okay, so the gag goes back in. Making sure that the tongue is central and that the gag is not pinching. In this case, there aren't any teeth, but if there were, making sure that the teeth are not being caught against the lip, for example. We're just going to change this pack because obviously it has been leaking. So we'll put a larger pack in. Someone has to take responsibility for putting the pack in and for taking it out, and I think it ought to be always the same person. I've just quite recently had an experience in another country of a pack being left in, not in fact my patient. So that's the width. It's about 14 millimeters wide at the back of the hard palate. Quite a wide cleft. So this is some ribbon gauze. A finger's a good way of putting it in initially, but I actually use the sucker handle often just to push it down. The endotracheal tube is a ray tube, which works very well for cleft patients. It is important to try and avoid the air leak or the gas leak around the tube. In other words, having a watertight pack, partly because partly obviously you want to stop blood dripping down to the trachea. Also you want to stop that bubbling, which is a nuisance, and also inhaling the gases. So there's the voma in the centre and the lateral segments. An incision in the midline of the voma. Coming up to the prevomarine suture there. Often bleeding at that point. There's obviously some major vessels around the point of the prevomarine suture. Elevating subperiosteally. And you can see the thickening of the prevomarine suture there. Elevating on both sides up to the prevomarine suture. And releasing posteriorly, making a little V incision back where near where the voma meets the pharyngeal roof, just to provide a little bit more vomarine tissue for closure. The success rate of vomarine flaps in unilateral clefts is very high. It's rare for them to fail. But in bilateral clefts, it's not at all uncommon for the more limited vomarine flap side to fail, and even for the more radical one, because the voma doesn't have that bend that you see in a unilateral cleft. Now the incision in the lateral segment, that's the junction of the oral and nasal mucosa, coming around a little onto the oral side, extending up to the back of the hard palate. And then I use a beaver blade, a 69 beaver blade, to make that incision at the junction of the oral and nasal mucosa, right at the edge of the cleft. Difficult to do that with other instruments, and that becomes continuous with the incision we've already made through the periosteum at the piriform aperture. And then getting into a subperiosteal plane, and that's can be quite difficult, trying to make sure that you don't make a buttonhole the oral mucosa, particularly at that point where there's a groove, which we're heading towards now, where the mucous glands of the oral layer are adherent to the bone. So using a knife to ensure that you're through the periosteum and down to bone. And because the palatal shelf is angulated, extending, you're going more nasally, more cranially as you go laterally, you do have to be careful about the direction that you put that scalar. If I turned the scalar around the other way, I'd be very likely to perforate the oral layer. Once you're in that subperiosteal plane, that mucoperiosteum elevates very easily. But you've got to negotiate past that groove in a subperiosteal plane. This is exactly the same area which is difficult in a palate repair if you're doing, for example, a cleft of the secondary palate. Lifting those mucous glands out of that point where they are adherent to the back of the hard palate and to the tensor palatine tendon more laterally is always a bit tricky. Combination of a knife and a blunt dissection with a scalar. Same incision on the other side, using the 69 beaver blade at the junction at the cleft margin. and the knife to make an incision at the junction of the oral and nasal layer. Getting down to the oral surface, the inferior surface of the palatal bone. And then again, taking care to get into a subperiosteal plane. The logical place to insert a vomerine flap is to the nasal layer, but I think the success of vomerine flap does depend very much, as the Norwegian team has shown, on overlapping. In other words, inserting the vomerine flap under the oral mucoperiosteum of the lateral segments. So you have to do some limited mobilizing of the oral mucoperiosteum. And it also makes sense to me to unfold that groove to some extent, to give a little bit of extra tissue, to move that tissue medially. Again, using the knife to make sure that you're in a subperiosteal plane. And using the both hands to do the work, it's certainly very helpful to develop a degree of ambidexterity in cleft surgery. Difficult to do that sort of maneuver with the knife if you're right-handed and you're using your right hand. I find this part of the procedure always difficult, to be sure of getting in that subperiosteal plane and not buttonholing the oral layer. Obviously, the vomerine flap procedure adds to the time and the complexity of the lip repair. Conversely, it makes the palate repair shorter and easier. We are in the process of trying to look at the growth effects of the vomerine flap in unilateral clefts, and so far have not seen detrimental effects, but as I said, I've only been using vomerine flaps since 1993, so 16 years or so, and we're still waiting for the final long-term outcomes in our patients. We haven't looked specifically at this stage at the growth effects in bilateral clefts. I wonder particularly if doing those few cases where we've done radical vomerine flaps on both sides, whether that may have produced some problems with growth. I find that the growth outcomes in bilateral clefts are very variable, I think, due to a lot of factors. So here we are then, again, back at that area where the mucus glands are very adherent, the mucosa is thin, the mucus glands are adherent to the back of the hard palate in that dimpled area, that grooved area, and where it's difficult, but I think important, to try to elevate those without buttonholing the oral layer if you can. So the key is to be in a subperiosteal plane. And then if you're doing a palate repair, that incision is just extended back in a subperiosteal plane until the tensor palati tendon is exposed. So when we do come back to do the palate repair, this limited part of the dissection will be repeated. We'll just go back through the same incision at the front of the soft palate at the junction of the oral and nasal layer. But in the lip repair, we're not really exposing the tensor tendon. Just lifting up a little bit at that point. And again, anteriorly that becomes continuous with the incision we've made around the piriform aperture, and becoming continuous with the incision that was made just above the sulcus on the anterior surface of the maxilla, and some gentle elevation at the edge there without damaging the tooth buds. So we're going to do a radical vermarine flap on the left side. It's easier to make this part of the dissection with the gag out. So we have made that incision around, as I said, just on the oral side of that groove, and we are going to continue the dissection of the vermarine mucosa up onto the side of the premaxilla, trying to keep it intact. There's the voma and becoming anteriorly the septal mucosa. So making sure that the incision has gone through the periosteum all the way around. And then putting that scaler underneath and making it, lifting it up to be continuous with the lateral margin of the C-flap at the edge of the prolabial dissection. It's not easy to get the vermarine mucosa out of that groove. It's more difficult still in a unilateral cleft. There's the grooved area where you sometimes need a knife to free it. I don't personally displace the septum or off the anterior nasal spine in a unilateral cleft, and certainly not in a bilateral where there's no indication to do it. As you can see, we still have a bit of irritating bubbling around the side of that throat pack. It is worth taking time to get that right at the beginning. So here we're coming up onto the cartilaginous septum and just making sure that that vermarine flap is completely free. Pushing the pack down a little bit further, hopefully to stop that bubbling. So we're now ready to put some sutures in to hold that interdigitated vermarine flap, which is placed underneath the oral mucoperiosteum. Just make sure that we've completely freed the nasal layer from the oral layer. So if you're coming in from the piriform aperture, lifting the lateral nasal wall, we've already separated the oral layer from the nasal layer more posteriorly, just making sure that it's separated all the way along, which it is. Now, we're going to release the lateral nasal wall to allow the lateral element of the lip and the alar base to come forward. And that involves, if it is necessary, that involves dividing the lateral nasal wall and sometimes dividing the turbinate. And here we're going to divide the turbinate. So the turbinate is also, the lateral nasal wall and the inferior turbinate is being divided at a point about a little over a centimetre behind the piriform aperture. Not too far back because you can damage the nasolacrimal duct. And it always bleeds a bit. And that's dividing it up to where the inferior turbinate joins the lateral nasal mucosa. It's a vertical cut initially, but coming forwards as you go superiorly to end up at the piriform aperture. And that provides the lateral nasal wall part of the closure of the nasal floor anteriorly. So the scissors actually go through the bone of the turbinate. I don't do this in every case. Again, it's a question of how far forwards you need to mobilize. In an incomplete cleft and a relatively undisplaced cleft, I would do just what's necessary. Sometimes not dividing the lateral nasal wall at all, sometimes dividing the lateral nasal wall but not the turbinate, but if necessary, both. And the bone of the turbinate is then removed, and I do often use it as a little graft on the anterior surface of the maxilla. So that lateral nasal wall dissection is now completed, and that's the bit of bone of the turbinate being taken out. It's only a small fragment. Most of the inferior turbinate remains. I'm not worried about producing dry noses because I think there's plenty of turbinate left behind. Maybe it's a good thing for nasal airway to effectively reduce the size of the turbinate anteriorly. Still not quite free. I think the principle in all this sort of surgery is do as much mobilizing as you need to do, but no more than you have to. And you can see now how that lateral, how the alar base lifts up into a reasonable position. You have to do this release of the lateral nasal wall before you sew in the Valmrine flap, otherwise you won't have access to it. Now the same release of the lateral nasal wall on the right side. You can see the turbinate there, so going from the front down the lateral nasal wall, again making sure that you've completely separated nasal layer from oral layer. We've already separated the layers further back with the beaver blade. So we'll just use the knife to join the two. It's still slightly connected at that point. there are all sorts of techniques for doing this, and Sam Nordhoff has his turbinate flap and so on. I try to keep the anatomy pretty much where it's meant to be, if you like. So I don't personally use mucosal or turbinate flaps. This is the time-consuming, or one of the time-consuming parts of this operation. Okay, so it looks as though that's now free. So the lateral nasal wall is free from the palatal oral mucoperiosteum, and you can then dissect that lateral nasal wall up to the turbinate, and here we are again making that vertical release of the lateral nasal wall and the turbinate using actually tenotomy scissors. It's such thin bone that the scissors cut through it very, very easily, the turbinate bone. So about 1.5 centimeters, not more, behind. What I'll tend to do in less displaced cases is to, for example, just release the lateral nasal wall up to the turbinate and then just see if it's free enough, and if necessary carry on and divide the turbinate. I've looked at a number of these turbinates through using a nose endoscope later, and I don't think this is a problem dividing the turbinate at this stage. Again, being careful of the nasolacrimal duct, not going too far back at that point. Quite oozy. A number of those steps are quite oozy. The vomerine flap tends to be quite oozy. The divided turbinate's quite oozy. We're just trying to make sure that we're getting that blood out. Obviously, the sucker's a little bit blocked. Okay. In this case, the height of the vomer is good, the access is good for the vomerine flap. There are occasions, there's a little bleeder on the front of the cut turbinate there, which I'm just by coagulating with the bipolar coagulator, and this is an area which often bleeds. That little V-shaped incision at the very back where the vomer meets the the roof of the pharynx is an area which bleeds, and often it's worth bipolarizing that. The key is overlapping, but here we're just going to make an incision or put one suture very posteriorly. I'm just mobilizing a little bit further. And you can see how you have much less vomerine tissue in a bilateral cleft because the vomer is just vertical. So the incision, the suture is a horizontal mattress stitch going through the oral mucoperiosteum, through the vomer, initially from inside out and then from outside in, and then back through the oral mucoperiosteum from inside out. So it's an overlapping, interdigitating suture. And I think that the success of the vomerine flap depends very much on that overlap. As I said earlier, the logical step would be or the anatomically logical step would be to sew the vomerine flap to the lateral nasal mucosa, but That's a single layered closure without overlap, and the chances of that breaking down, I think, are very high. Certainly, talking to colleagues who've done it that way, I don't think it's very successful. We're using here 5/0 Vicryl on a compound curved needle, which is very nice for getting into difficult areas. Putting that suture laterally just to make sure that it's well anchored, and then just seeing how well it pulls into position. And I usually leave these to tie at the end, just leave them long, put the 3 or 4 that we're going to put in, and then tie them all at the end. Otherwise it's quite difficult to see what you're doing. So usually 3 or 4. So again, a horizontal mattress stitch. And the overlap is probably 5mm or so. In other words, the vomerine mucosa extends perhaps 5mm underneath the oral layer. You can see how that compound curved needle is very nice for getting into that area. And again, I'm going laterally there, through lateral to the grooved area. You can argue that it would be better to go more medially, but it's quite thin and friable. So just to make it solid, I'm going lateral to the groove. In other situations, I might go medial to the groove. The advantage of an unedited tape is it shows you the bits where you're having some difficulty, and this is obviously one. Just trying to get the angle of the needle right. This operation was actually done as a demonstration to a number of visiting British surgeons, so you can sense a little bit of the frustration at some of the bits that are not going terribly easily. But as I say, I think it's quite useful to see the bits where you have a bit of difficulty. It's very easy to do an edited tape, which we take out all the difficult bits. The spacing of these horizontal mattress sutures is not too critical, I think. It's just to try and produce a good overlap. A little bit more difficult as you come up towards the alveolus, because the oral mucoperiosteum is less mobile. That one's gone very far laterally, but at least it's secure. This 5/0 Vicryl has disappeared by the time we come back to do the palate repair in 3 months, in other words, when the child is 6 months old. Vicryl doesn't knot terribly well, and I do think it's important to try and produce surgeon's knots and not a series of half hitches, so running the knot down in the right plane. I find a swab is a better way of getting the blood out and seeing what you're doing than a sucker, often. I've typed those two just to see where we are. Now I'm going to just, this is not a mattress suture, but a suture from the oral layer down to the posterior end of the membrane flap to anchor it posteriorly. There's not enough membrane flap to be able to do an overlapping mattress suture. And I sometimes also put some fine PDS sutures. I tend to use 6.0 PDS to improve the apposition between the oral layer and the oral mucoperiosteum and the membrane flap by just putting some very fine sutures through the very edges of the oral flaps to the periosteum on the inside of the membrane flap. Otherwise, you can have a situation where the point of contact is only just where the suture is. So here we're putting a little fine stitch through the periosteum of the membrane flap, and then through the edge of the oral mucoperiosteum. The problem with bilateral clefts is that in our series they're about 10% of total. That obviously needs to be repeated because it's just pulled out of the periosteum. And so depending on the volume, the workload of the unit that you're working in, or your personal workload as a surgeon, you may not see many long-term results of bilateral clefts. Our centre now treats about 150 new babies a year, which is a lot by Western standards, but small compared with centres in India and China and other parts of the world. But even still, the volume of the numbers of long-term results of bilateral clefts, particularly as the numbers were not as great 20 years ago, is often, it means that you don't learn, you don't see your results, you don't see enough of your results to know whether what you've done is right or wrong. So it is one of the big arguments for centralisation and doing good numbers. There has been an argument in the UK that perhaps only 1 or 2 units in the whole country ought to be doing bilateral clefts so that they get enough numbers. This is obviously not a problem in some other parts of the world. So I might on occasions do 2 or 3 of those stitches if it looks as though the contact between the 2 layers is not very firm. Just freeing up the vomerine flap on the right side again. You do have to be very careful around the point of the prevomerine suture. I have fractured the vomer at that point. I know other people set back the premaxilla in difficult cases. I've never done that intentionally. I think that the price to be paid in terms of long-term maxillary growth is just too great. So I would always tend to compromise in the lip surgery at this stage, and as I said before, be prepared to go back and do a second stage lip reconstruction, for example, with muscle reconstruction, rather than taking what I think is the easy way out of fracturing or pushing back the premaxilla. So the vomerine flap on this side is significantly mobilized only up to the prevomerine suture. So again, 2 or 3 overlapping mattress stitches. I think the problem with bilateral clefts is that some of those patients that you get just right at the age of 2 with the premaxilla back and at the right level are retruded at the age of 20. And some of the ones where the premaxilla is still prominent at that age actually end up much better. The vertical position of the premaxilla is in many ways more difficult than the anteroposterior position, and the low premaxilla is a particular challenge, particularly a challenge to the orthodontists. As far as the vomerine flap is concerned, we have had a few cases of reactionary bleeding. I think 3 out of 150 unilaterals, just looking at one series, had some bleeding. Generally, there's no specific bleeding point, and going back to theatre is not very helpful. The one thing that we are doing more and more is to use tranexamic acid, an antifibrinolytic agent, if there's any doubt, 10 milligrams per kilo, during the operation, if the patient is oozing more than normal and we're worried about reactionary bleeding. If a needle is in a difficult position, I think it's a good idea to use a pair of non-tooth forceps rather than a needle holder to try and get it out, because a needle holder can only make it go in one direction. With a pair of non-tooth forceps, it'll rotate and it'll come out in the least damaging way. Those stitches shouldn't be too tight. And again, trying to run them down to make surgical knots. And usually 3 throws for Vicryl because of its rather poor knotting qualities. Now, in front of the prevomerine suture, I will make an incision, but I simply don't mobilize the vomer very much. So we're just being very gentle at the point of the pre-vomerine suture and just deciding whether we can put a stitch on that side. Choosing which side to do the radical vomerine flap is usually based on the principle that the radical flap is done on the wider side, partly because it's easier to see what you're doing, partly because that means that the vomer is tending to curve away to the narrower side, and you have a bit more vomerine tissue therefore on the wider side. Here again, one of these little 7/0, 6/0 PDS sutures, just improving the apposition between the oral mucosa and the vomerine flap. But you can probably sense that the closure on that side is not as good. Put another one of those in. The PDS sutures to improve the overlap. As I said earlier, in a unilateral cleft, you can be fairly confident that the vomerine flap will work. In a bilateral cleft, in this case, I'd be reasonably optimistic about the left side and less sure about the right. It's always a pleasure when you come back to do the palate repair to find that the vomerine flaps have done their job. And what happens is that this area epithelializes, the neo epithelium grows on the raw surface of the vomerine flap and over the premaxilla. The gap narrows to some extent, and you're left then with, ideally, if all goes well, a cleft just of the soft palate to repair. You can then base a flap of neomucosa posteriorly, so actually make an incision coming forwards. This is at the time of the palate repair, but at a V-shaped flap or U-shaped flap, beginning the incision at the junction of the oral mucoperiosteum and the new epithelium, and lifting that flap, turning that flap back to close the anterior nasal layer of the soft palate. In a unilateral cleft, that's easy to do. In a bilateral cleft, it's more difficult because you've got the vomer in the midline, and you've got to be careful not to make a hole through it, but it's still often possible. In the unilateral repair demonstrated in this series of DVDs, the palate repair in the same patient is demonstrated in the series, and that V-shaped flap is demonstrated. So just another one of these 6/0 PDS sutures just to improve the overlap on that side, which is more precarious than on the left. Well, we've now gone forward a little, having almost completed the vomerine flap closure, just to begin now the dissection of the of the lip on the lateral element of the lip on the right side. Just removing that junctional area a little more. And doing some muscle dissection. Separating the muscle from the skin on the right side. I do this always with a knife. It's, I think, much easier to get in the right plane. And I make that incision, that dissection, close to the dermis. It's very easy to make the orbicularis muscle, the lip muscle, too thin. And as you come down to the white roll and the vermilion, you've got to be very superficial because the muscle goes very close to the skin at that point. So using the knife, just curving around to make sure that all the muscle is in that muscle dissection. And then as you come around onto the mucosal surface, there's a clear plane between the mucous glands and the muscle. Getting the muscle dissection right in a bilateral cleft is obviously even more important than any unilateral cleft. And that dissection carries on up to the alar base. A little more dissection away from the nasal mucosa, so that the nasal mucosa, the lip mucosa, so that the mucosa is free, and then dividing the muscle from the alar base. All by knife dissection. And we can just feel how mobile that area is now. Remembering that we want to take that point of the mucosa at least to the midline. Just making sure that the C-flap is freed up to the top. But of course being very careful not to damage the blood supply of the prolobium in the process, because it's quite a thin flap. And obviously we have cut through a little vessel there, so being very, very careful about bipolar coagulation. Now, I am mobilizing the skin from the alar cartilages of the nose, and I found it easier in both the unilateral and bilateral clefts to start medially, because you go up in a plane between the two medial crura, and you are automatically in a plane between the skin and the alar cartilages. So here we are mobilizing on the right side, and similarly on the left, using tenotomy scissors, and up over the bridge of the nose. So a la Harold McComb, basically, although I think he would do it more radically. And you can actually see that you're in the right plane. If you do the nasal mobilization from laterally, it's easy to get in the wrong plane. I used to worry about the effect of doing this on the vascularity of the prolabium, but I think as long as you're sufficiently deep, those little superficial vessels, the columellar vessels that maintain the blood supply of the prolabium, remain intact. And I haven't had any problems with devascularization of the prolabium. Now, having done that dissection from medially, we're going to dissect from laterally. And hopefully get into the same plane, become continuous to the plane we've made from medially. And then just see how that's going to come together. Of course, it's not going to be perfect because the columella is short. Still some irritating bubbling around the pack. Just thinning the prolabial mucosa a little. What you really want to do is to sit down on the premaxilla as much as possible. There's always less attached gingiva in the premaxilla of a bilateral cleft. But if you're not careful, you can be left with a fold of mucosa that's visible, where that mobile mucosa on the premaxilla protrudes down below the lip margin. Okay, now the muscle dissection on the left side, freeing the mucosa. We just want to get a feel whether that mucosa is going to come together in the midline. Okay. There are a few key stitches now. I think it's quite useful at this point to do the mucosal stitch. So but first we have to complete the closure of the nasal floor. We've already interdigitated the vomerine flap up to the level of the alveolus, underneath the oral mucoperiosteum. At the alveolus, the closure changes, and the vomerine flap is sutured to the released lateral nasal wall. So that stitch has gone through the lateral nasal wall at the point where the vertical releasing incision was made, and it's now going through the vomer. being careful not to restrict the forward movement of the alar base that we've achieved by doing that lateral nasal release. So making sure that we can still bring that left alar base up into the right position. So this is a 3-point stitch. It goes through the alveolus, the alveolar margin, through the lateral nasal wall at the point where that lateral release was made, and through the vomer, hopefully to avoid a fistula at that junctional point. Having said that, I suspect very often there is a small residual fistula. So this is these can either be simple sutures, again using 5/0 Vicryl here, or better still, if there's enough tissue, a vertical mattress to get some eversion and good apposition of the 2 layers. So this is a vertical mattress stitch. So it's another single layered closure, and it's in this case you can't interdigitate, so it's more precarious. So the better the apposition you can get, the better the contact between the two, the lateral nasal wall and the vomerine mucosa, the more likely that you will avoid a defect at that point. This is anatomical. It is, after all, joining the lateral nasal wall to the vomer where it should be joined. And as I said, not actually displacing the septal or the vomer or the septal cartilage. So another vertical mattress stitch here. And as you come further forwards with these sutures, the nose begins to take shape. And once again, you can see where how the incision at the edge of the vomerine flap becomes continuous with the C-flap. So there's the C-flap coming into view anteriorly. And constantly making sure that you're not actually holding the alar base back by putting those sutures too far back in the vomerine flap. I certainly don't believe that I've got all the answers about bilateral clefts. I don't believe I've got the answers about anything, actually, but particularly about bilateral clefts. I think they are difficult. I think the long-term results are often disappointing. I think no matter how careful you are with the muscle repair and dissection, I think it's rare to see a bilateral cleft where the lip musculature moves in a normal way, or in a reasonably normal way. Unlike a unilateral, where you should not see any significant abnormality in the muscle function. But in a bilateral cleft, I think getting that prolabial muscle to function normally in speech and so on is a challenge, a real challenge for the future. But when you think about the complexity of the muscle insertion into the prolabium, it's perhaps not surprising that we can't quite reproduce that. I think the main thing is not to make it so tight that you devascularize it or scar it or make it inactive, and that comes back to I think the best plan in the very prominent premaxillar patients to do a staged repair, to come back and do the muscle, perhaps at 12 months or so, and simply at the primary repair to simply put a stitch through the muscle, through the prolabium, but not dissecting it. That's where we've closed the nasal floor more posteriorly. But again, there's that junctional area, which on this side, where we've done a less radical vomerine flap, is even more precarious. The junctional area between where we've sewn the vomerine flap and where we've interdigitated the vomerine flap, and where we're closing the vomerine flap to the lateral nasal mucosa. What we're doing here is using the microscope to take the picture, not necessarily always operating through the microscope. As I said, I don't normally use the microscope for a lip, but it's just to provide a good picture. Just looking at that junctional area again, where the vomerine flap needs to be closed as much as possible on this side to the lateral nasal mucosa, and I would normally do this before closing the nasal floor, but this is in this case doing it afterwards, having closed the front of the nasal floor. But I think we can be fairly sure that this will not be watertight at this point. I don't use Vowardle or Bardak two-flap repairs of the palate. The most that I would do Langenbeck lateral releasing incisions at the time of doing the palate repair. So it is possible to deal with these defects, but usually the fistula, the alveolar defect, particularly on this side, would be dealt with at the time of alveolar bone grafting. There's the released lateral nasal wall that you can see there. Okay, so we're just checking that there's enough mobility there. So I'm just going to put another marginal stitch there. Not happy that it's sufficiently watertight. Through the gingiva. And through the vermilion flap at that point. So this is identifying a couple of less than ideal areas of the vermilion flap repair before carrying on with the lip repair. And that's putting the little bit of turbinate bone in on the anterior surface of the maxilla at that point. Whether the idea is that you stimulate a bit of new bone formation at the alar base and on the anterior maxilla. I think elevating the periosteum does that. Whether the little bit of bone makes any difference, I'm not sure. Now the alar base cinch stitch. This is through that tissue at the alar base, going from one side to the other, using usually 4/0 or 5/0 nylon, non-absorbable suture, and really a key stitch in getting this right. Getting the position of the alar base symmetrical in all planes, or trying to. As this stitch will go back through the base of the columella, really. I'll usually in a bilateral cleft put one stitch between the two, but in asymmetrical clefts sometimes you need to advance one side differentially, so maybe putting an extra stitch on one side towards the anterior nasal spine. So we're just going to put a clip on that at the moment, an artery forcep. going to put a separate one on the right side. And to the left. And I spent some time doing this stitch, and if necessary replacing it. I just want to see that it's as symmetrical as possible. You see the left side doesn't come in quite as well as the right side doesn't come in quite as well as the left. Now the mucosa, I've not tied those cinch stitches because they tend to make it more difficult to close the mucosa. So a stitch through the angle of the mucosa, through the tissue on the premaxilla, to the other side. And you see we've actually advanced that lateral mucosa on the right. So the hook is actually in the angle of the mucosa, and that's a more lateral suture. Again, this is using 5/0 vicryl. Same thing on the other side, suture through the prelabial premaxillary mucosa laterally, through the lateral mucosa, a centimetre or so lateral to the angle of the prelabial mucosa, and taking the strain off basically, but also defining the sulcus. Now a stitch through the apex, through the angle, through the midpoint of the premaxillary mucosa, back through again, and through the left angle. And this is the point that where you say some rude words to the anaesthetist, as the baby's a bit light. So bringing that mucosa together, and then we just see how it's going to make sure that the mucosal length is equal on both sides. And I'll put a couple more of those vicryl sutures in. Again, making sure that you've got the same length on each side. Anesthetic control restored. When you see how unsatisfactory the bilateral cleft repair is, you really wonder how the results end up as good as they, imperfect though they are, how they end up as well as they do. We are going to show at the end of this procedure this child at the age of 2 years, so you can see a somewhat later result. Okay, so now we can tie those cinch stitches, those Ayla base stitches. Again, running the stitches down and bringing the Ayla bases well in. And the early bases look fairly symmetrical. Obviously there's some work to do to the rim. The two problem areas of the nose, the rim and the web, which we'll address at the end of the procedure. So we've used 2 transalar stitches in this case. Now a stitch, this is actually 6-0 monocryl, a stitch to line up the mucosa. So from a point, perhaps 3 or 4 millimeters from the vermilion margin on each side, what I then normally do is to put an artery forceps on each end, and that just gets the mucosa correctly aligned to make it as accurate as possible, to make the mucosal repair as accurate as possible. Then we can put some more sutures in the mucosa more posteriorly. But we know that when we get to the end, it's going to be lined up accurately. Just trimming a little bit of the margin. So I tend to use 5-0 vicryl superiorly in the tension sutures, and then more inferiorly where there's less tension I use 6-0 monocryl. And I think this is important, both in unilateral and bilateral clefts, to get this mucosa lined up as accurately as possible. Sometimes put in some mattress sutures at this point just to evert the mucosa. In the Manchester type repair, what you're doing, where you leave the prolabial mucosa attached to the prolabial skin, you end up doing the same thing with the apices of or the angles of the vomerine mucosa superiorly, but then you're inserting a V-shaped flap of the prolabial mucosa in at this point. So you're not bringing this mucosa to the midline. And you then just need to decide how high up you insert it. One other disadvantage of the potential disadvantage of the Mullick and Millard type repair, this type of repair, is that it does leave you with a transverse scar just at the vermilion margin. We've had a couple of patients who developed rather unsightly hypertrophic scars at this point. And if that happens, it's very difficult. You can't very well excise it because you haven't got any spare tissue. On the other hand, I think that the benefit may be that having a transverse scar helps to stop the prolabium stretching, because the natural tendency for the prolabium is to stretch. Now we're putting in some muscle stitches, and this is 5050 nylon, and that's the inferior muscle stitch. In a unilateral cleft I overlap the muscle, but I don't in a bilateral. I'm simply trying to get the muscle together. So a stitch in that very inferior part of the orbicularis muscle. And an artery force upon it, and I tie them at the end. I like non-absorbable nylon sutures for muscle because I know it's non-reactive. I know it's going to stay there, it's not going to absorb too quickly. And I've had, I would say, no problems with those sutures in the muscle. I have had a couple of patients who've had some problems with the cinch stitch, the nylon cinch stitch, but very uncommon. So this is the second muscle stitch at about the level of the vermilion margin, and constantly just checking the orientation of where these muscle stitches go, because if they're at the wrong level, you can't get the skin right. Usually 4 or 5 muscle stitches. So I wasn't quite happy with the level there, and I'm repeating it. That looks as though it's going to line up the skin and the vermilion margin accurately. Another one just above the vermilion margin. Another muscle stitch, trying to make sure that the knot on the muscle stitch is on the deep side. By dissecting that muscle carefully, by dissecting close to the dermis on the outer side of the muscle and getting in a good plane between the mucous glands and the muscle deeply, you try to ensure that the muscle is a good, strong layer. And taking reasonably good bites of the muscle. But there are situations where I believe this just can't be done safely, and those are the cases where I do a two-stage repair, do the lip repair later, do the muscle repair later. Okay, we're now going to tie the muscle, so far 4 muscle sutures. Starting inferiorly. I think I'm right in saying that Jean-Claude Talmont from Nantes tends in a bilateral cleft not to close the lower part of the muscle, and has some very nice results. It's presumably the muscle simply joins up, and certainly this tightness of the muscle is a worry in bilateral clefts. But this is coming together without hugely excessive tension. Obviously it's putting the skin in a position where hopefully the skin closure can be relatively tension free. Again, a couple of throws initially, and then 2 or 3 throws in the nylon. I have a little routine where I cut these stitches because I don't want long ends left, because I think that they can potentially cause problems, so I cut them myself. So I'm responsible if they're not at the right position. Just making sure the muscle is coming together nicely. And hopefully these muscle stitches are not too tight. This operation was done in 2006. I think October 2006. Now the skin I close with 8-0 nylon, 8-0 ethylon, and I'm going through here the middle, the subdermal stitch in the middle of the prolabium and to each corner of the vermilion margin, to get the midline right. I like 8-0 nylon just because I think anything, certainly 6-0 I find is a bit crude. In other situations I would consider using, we're going to put this one in again, an absorbable suture such as 7-0 Vicryl Rapide. I just need to be convinced that using that as a routine is as good as far as stitch marks are concerned, and as reliable as using fine non-absorbable nylon. It's a bit of a challenge for removal. Our nurses take the stitches out under sedation usually. But it obviously is a challenge on a small baby. So putting this, trying again to get this stitch right. What you're really trying to do is to make the white roll of the from the lateral elements a little bit proud, standing out a little from the prolabium skin, just to give a nice white roll. I think you've got to be prepared to take stitches in and out, and until you're happy that you've got it right. Now the lateral prolabial stitch. Still got that bubbling, and putting a swab in just to stop it, get rid of it. So again, through the lateral corner and to the corresponding point on the lateral segment. Sensible to leave those ends reasonably long to make the suture removal fairly easy. I think that sort of bulging that you see in a bilateral cleft often is not surprising when you think that the skin becomes almost redundant because the mucosa is, the muscle is under more tension. Now a stitch through the upper end of the prolabium and through the upper end of the lateral incision. Being careful when you do that not to strangulate the prolabial flap. So a small bite of the prolabium and an angle stitch here through the dermis of the lateral element. But making sure that those bites in the prolabium are small bites, so easy enough to put the stitch too far medially and end up compromising the blood supply of the prolabium. You can see the C-flap waiting to be sewn into the nostril sill. Same stitch on the other side, small bite at the angle. Picking up the dermis of the lateral flap. And again back through the angle. And again a small bite. So those are the important sutures, and then the others are fairly straightforward, except sewing in the C-flap, and I think being careful about that is worthwhile. The prolabium does lengthen in these patients. It does look short now, but it does lengthen. With these sutures, trying to pick up a bigger bite of dermis than epidermis, so that there's some eversion of the edges. Again, trying to produce some eversion, so there's good dermal apposition. Ideally bigger bites of the dermis than the epidermis. You see the blood supply of that prolabial flap is fine. I think at best in the right patient with a nice white roll in the lateral segment and with good quality scars, the Malik and Millard technique does give some very nice results. But I've seen some very nice results with preservation of the prolabial mucosa also. So I think it is a matter of picking the patient and looking carefully at the anatomy. I use 3.5 times loops. Normally, as we said, this is actually being recorded through the microscope, but normally in a lip repair I use 3.5 times loops, 40 centimeter focal length. It would be very nice to use the microscope for doing lip repairs. I think the argument against it is that you do get less of a three-dimensional impression, and this is a three-dimensional operation. Unlike a palate repair, which is, if you like, almost a two-dimensional operation, and where I use the microscope routinely, a lip, you need to be able to move the position of your head constantly, see whether you've got things right in the different planes. And so I think for routine use, I don't think that it's ideal to use it. Now I'm trimming that C-flap a bit because it's a bit redundant. What you can do is to use the microscope for the bovine flap. That's quite nice, except it does mean moving it in and out as you go from front to back. So they're trimmed C-flaps. And as I said, trying to insert them into the nostril floor. In a bilateral cleft, what can happen is that the premaxilla becomes retroclined, tips back. As it does so, the lip sort of drags down, and the C-flaps become visible at the top end of the lip, become prominent and unsightly. I think that the reason that bilateral clefts tend to lengthen, so sometimes end up looking too long, is because of that retroclination of the premaxilla. So each time, if the premaxilla is retroclined, each time the patient smiles, for example, the lip is being pulled down the retroclined premaxilla. So this is an angle stitch through the tip of the C-flap to the lateral end of that incision at the alar base. But it does mean we have got some tissue stored there for columellar lengthening in the future. As I said, usually with a V/Y type advancement, not the old radical forked flap procedure. I think there's a good argument actually for using absorbable sutures in some of these superior sutures where stitch marks are not likely to be a particular concern, and where they're quite difficult to remove. Our nurses have asked us to do that, but I didn't do it in this case. In this suture, producing a deeper bite, if possible, of the skin of the lip flap rather than the C-flap, just to try and get the C-flap out of the way. So the apex of the left C-flap. Reasonable symmetry of the alar bases, but some work still to do to the rims. So just sewing in the flap on the C-flap on the left side. The little needle on the 8/0 nylon is a little bit awkward to use. But another angle stitch. I usually assume that a bilateral cleft like this will take 2.5 hours. With foam rind flap, 2.5 to 3 hours. This being a demonstration case is a little slower, and as often happens in demonstration cases, a few bits that prove to be a little bit more difficult than expected. I like using the C-flap to recreate a nostril sill. I've always felt that's one of the advantages of a traditional Millard repair compared with, let's say, a Tennyson repair, where often the nostril sill is rather deficient. But I've also seen some very nice results in patients who've, at least earlier results in patients who don't use the C-flaps in this way and don't make the alar base incision. This is a compromise. This is, as you see, a small C-flap and a small alar base incision. Now, a suture at the back end of the C-flap to the lateral nasal wall to try and pin it down, as I said, in the nasal floor, so that it's not sticking out. So this is 6-0 monochrome. And the same on the right. Pin it down in the nasal floor. You can see that right eye is a little open, so you do need to be careful about that. But I prefer to see the eyes. So we've still got a slightly depressed nostril rim and the alar webs, and I use this technique. I used to use Macomb type stitches. We're now looking rather from below. I used to use Macomb stitches, putting sutures through the rims or the domes and tying them over bolsters. Now I use what I call a sewing machine stitch. This is a blue needle, 21 gauge needle, and it's inserted from the skin of the bridge of the nose down to the nostril rim, and it's curved manually to try and get the right sort of curve so that it'll come out in the right place, with the bevel facing towards the concavity of the curve. The principle is to put in a PDS suture which will last for maybe 3 months. My concern about the Macomb bolster sutures was that they were only there for 5 days before the stitches came out, and then the benefit was lost. So the principle of this technique is to support the nostril rim, the alar domes, for 3 months. I'm not sure that that's produced significantly improved noses than the earlier technique, and undoubtedly the PDS sutures do lengthen to some extent. Of course, in time they dissolve, and they probably give way superiorly. However, this is a useful technique. That's just to demonstrate the sort of curve on the needle and the bevel pointing up. So we're going to put the stitch from the right side of the bridge through the rim, or close to the rim, on the left of the left alar. And then a 5-0 PDS suture is threaded up through the needle. And then the needle is withdrawn, almost out through the skin, but not quite, and then redirected back towards a place quite close to or next to that area, but through a different route. So the aim is to take a purchase on the deep tissue, not probably the periosteum, but the deep tissue, the deep fixed tissue on the bridge of the nose, so that you've got a fixed point to which that alar rim can be lifted. Trying to stop that drooping of the soft triangle. Then you simply pull the needle out and tie. You need to view this improvement in both this worm's eye view that we're looking at now, but also from the front, because the alar rim does tend to droop downwards. Once again, we're trying to achieve symmetry, so we could do the same on the other side. I put a variable number of these sutures in, and I use a combination of these sort of stitches, what I call sewing machine stitches, because it's like the principle of a sewing machine, and what I call Nordhoff sutures, which I've seen Sam Nordhoff demonstrate, which are sutures that are actually put out through the skin and back through the skin, but very close to or through the same hole, but again directed in a different direction. Sometimes with putting these sewing machine stitches in, you get a bit of dimpling of the skin, but it seems to correct itself. So the same thing, withdraw, almost out but not all the way, pick up some deep tissue, feel it go through in a different direction, and then back, and then through a point a little lateral to the point that we've just gone through, and close to the rim, but not too close. Those who advocate NAM would probably say that this is much easier if you've expanded the alars, but we need to see what the long-term result of that is. Now I'm going to do another stitch, another similar stitch, but this time picking up the web. So rather more lateral on the left side. Thread it up through that needle. Same thing, almost out but not quite, and a different route through. That time it didn't work because I came out through the skin, so we need to repeat it. The stitches do remain for 3 months or so. When we come back and do the palette repair at 6 months, these stitches are usually still there, so it does last quite a long time. But, as I said, you do get some give. Presumably, I think the stitches stretch and they presumably gradually work through the fixed point that they've been, or the relatively fixed point that they've been attached to. In this case, the ailered domes seem to be quite nicely together, but sometimes I will put a stitch from one dome to the other using the same suture material. So this is the other way of doing it, what I call a Nordhoff stitch. From inside out through the skin, back through the same hole, but then from then on going through a different route. And you get temporary dimpling, and as Sam Nordhoff said to me, the dimpling doesn't remain, and it doesn't. I've never seen it persisting. Again, I presume because the stitches give a bit. So it's an alternative way of holding, particularly the web, out, because you've got a less obvious fixed point or less fixed tissue to sew to with that more lateral suture. I have on occasions put this is a Nordhoff stitch on that side also. I have on occasions put tubes in each nostril. It's an option. We don't use formers, retainers. Again, I think it's always just a matter of working out whether the benefits, the long-term benefits, justify the extra cost and the extra inconvenience, the extra burden of care for the parents. Again, I'm neutral, I'm agnostic, uncertain whether that's a good move or not. So, we're now just looking at the side view, oblique view. The nostril rim looks reasonably corrected. There's a reasonable columella, but of course we've not achieved significant columella lengthening. I'm sure that the current view that the columella is in the nose and not in the lip is basically correct. Another little suture through the midline mucosa with some 6/0 monocryl or some 7/0 vicrolipide. Sometimes putting some little mattress sutures there to get some eversion, prevent grooving in the midline. Okay, little cleanup. And a Marcaine injection in the infraorbital nerve. As I said earlier, it's actually probably easier to do that after you've elevated, from below, after you've elevated the maxillary periosteum, and ideally before you incise the periosteum. You can put it in then and it'll just sort of produce a little bleb, and you've got good exposure. So, slightly out of focus. There's the end result at this stage. Probably better slightly out of focus. And most importantly, remove the pack. And check that there's no bleeding from the boomerang flap. So here's this little girl at the age of 2 years. Still the fairly typical broad nose and still the prominent upper premaxilla. We would regard that as a good sign at this stage, and I'm not concerned about that. That's hopefully optimistic for future growth. Obviously there's some more surgery to be done later, possibly a nose tip revision with columella lengthening.